All right, today we're jumping into a huge topic, a real revolution in how we treat opioid addiction. It's a story all about how one powerful and frankly dangerous substance has completely changed the game.
Let's just start with the tough reality here. Fentanyl's presence in the illicit drug supply, it's changed everything. It's now the #1 cause of substance-related overdose deaths in the US. That's the landscape we're dealing with.
So that leads us to the big, critical question, right? In this new era of fentanyl, how do our tried and true treatments for addiction actually hold up? Okay, so here's how we're going to break this all down. First, we'll get a handle on the new reality of fentanyl. Then we'll talk about a life-saving treatment called buprenorphine. After that, we'll dig into what's called the induction challenge. This is a big one. Then we'll look at how doctors are adapting the playbook, and finally, what the path forward looks like. All right, first up, fentanyl. Look, to really get a grip on the solution, we absolutely have to understand why the problem itself is so different this time around. This isn't just another opioid. So take a look at this. This table really lays out the key differences between fentanyl and, say, heroin. Yeah, it's way more potent, and it hits you faster. But the real game changer, the thing that messes everything up, is that third property down there. It's lipid soluble. Basically, it stores in your body fat, and that's what makes withdrawal so unpredictable. And this whole lipid-soluble thing, lipophilicity, this is the absolute crucial point. You have to get this. Think of your body fat acting like a sponge for fentanyl. It just soaks it up. And then it slowly leaks it back into your bloodstream, long after you've last used. You can see how this creates a massive problem when you're trying to figure out when it's safe to start treatment, right? Okay, so with that challenge in mind, what's our main weapon in this fight against what doctors call opioid use disorder, or OUD? And before we go any further, it's so important we're on the same page about what OUD actually is. This is not a moral failing. It's not about willpower. It's a recognized medical condition, a health issue that needs a medical solution, period. And here is our hero in the story, buprenorphine. This medication has been a total cornerstone of OUD treatment for years. Now, two things make it super special. One, it's a partial agonist, which means it has a built-in safety ceiling on its opioid effects. And two, it has a high affinity for the brain's opioid receptors. That means it grabs onto them and just doesn't let go. But, and this is a big but, this is where the plot really thickens. The very thing that makes buprenorphine so good, that tight grip, is what creates a really dangerous conflict in the age of fentanyl. This is what we call the induction challenge. So to really get this, let's use an analogy. Think of buprenorphine's high affinity as being like a super powerful magnet. When you introduce it into the body, it's so attracted to those opioid receptors that it literally rips any other opioids, like fentanyl, right off of them. And that violent ripping off action, that triggers something called precipitated opioid withdrawal, or POW for short. Just imagine, you're seeking help, you're expecting relief, and instead, boom, you're thrown into the worst, most abrupt, most severe withdrawal of your life. It's incredibly distressing, and it can be a huge setback for someone trying to get well. And remember that fentanyl sponge we talked about, the reservoir in the body fat? Well, that's the villain here. See, a person might feel like they're in withdrawal, ready for treatment, but because fentanyl is still leaking out of their fat, there's still enough of it sitting on those receptors to cause a massive problem when the buprenorphine magnet shows up. It makes timing the start of treatment an absolute minefield. So what are doctors doing? Are they giving up on this life-saving medication? No way. They're rising to the challenge. They are adapting the playbook. And this table here shows you exactly how they're doing it. The old standard way isn't always cutting it. So now clinicians are using these new approaches, like low-dose and even microdose inductions. The idea is to start with incredibly tiny amounts of buprenorphine and slowly, gently introduce it into the system. You sneak it in, so you avoid that sudden shock of withdrawal. It's all about being more flexible and creating a customized path to treatment for each person. And this is so important. Even if precipitated withdrawal does happen, it's not the end of the road. It is manageable. Clinicians can actually use more buprenorphine to push through and stabilize the system. They can treat the symptoms, the anxiety, the pain, the nausea, and just provide that crucial support to get the patient through it. It's a hurdle, for sure, but it's not a barrier. So, with all this change, all this adaptation, what's the big takeaway? What's the path forward? Well, this really says it all. This is the core message from the experts. Even with all the challenges fentanyl throws at us,
Opioid use disorder is still a highly treatable condition. Let me say that again, highly treatable. The tools we have work, and we're just getting smarter about how we use them. So, the crucial takeaway, the thing you have to remember, is that there is no one-size-fits-all solution anymore. The fentanyl crisis demands that we be flexible, that we provide individualized care. The right approach is simply the one that works for the specific person sitting in front of you, the one that gets them safely onto this life-saving medication. And that leaves us with one last, really vital question. We know the treatments are effective, we know the playbook is adapting and getting better, so the question becomes, how do we make sure that everyone who needs this care can actually get it? That's the challenge that takes us out of the doctor's office and into our communities.